Hello, welcome to Crush My Dental Boards. Our topic for today is antimicrobials used in dentistry. So some terms to review. So we have your bacteriostatic drugs, which just inhibits your microorganisms, and we have your bactericidal drugs, which kills. Another term would be spectrum, so it pertains to the extent of organisms affected by the drug. So spectrum, when we talk about spectrum, it can be broad, it can be narrow, and or extended. So if it's narrow spectrum, it means it just affects a small number of microorganisms when it comes to like type. But then for broad and extended spectrum um, drugs, they can affect a broader range or different types of microorganisms. And then there's the term drug resistance. It just means that after repeated use of your drugs, the bacteria or the fungus or the virus can become resistant to it. Okay, and then another term is super infection, meaning there are times that when we're treating a certain type of microorganism, another kind of microorganism would infect that person. Okay, so it's like super infection. It's an infection on top of an infection. Okay, so those are just some review of terms. Okay, so now we'll talk about antibacterial. So it's against bacteria. Now, when we talk about antibacterial drugs, there are different modes of action or there are different means in order for the drug to kill your bacteria. So some of the mechanisms of action of your antibacterial drugs would be cell wall synthesis inhibitors. So it affects the cell wall. Okay, so some of them can disrupt the cell membrane. So they don't have anything to do with the cell wall, but they disrupt the cell membrane. Some of them would affect, the genetic material of your microorganism. Some would affect your ribosomal unit, either the 50S or the 30S subunit. And then some of them would affect the mRNA or your messenger RNA. And there are some antimicrobial agents that would actually affect the synthesis of some metabolic components that is needed by your bacteria, such as your PABA or your para-aminobenzoic acid. We'll talk about these different types of antibiotics, but mostly we'll concentrate on what's being used in dentistry. Okay, so first off, we have antimicrobial drugs or antibacterial drugs that inhibit cell wall synthesis. Okay, so these types of drug would target one of the steps in the formation of the peptidoglycan. So we all know that peptidoglycan is the important component of your cell walls. So because it affects cell wall synthesis, then this type of antibacterial drug would be effective against bacteria with cell walls. Okay, example of which are your beta-lactams. Under beta-lactams, we know them more commonly as your penicillins and your cephalosporins. And then we have vancomycin and bacitracin. So these are the three types of antibacterial drugs inhibiting cell wall synthesis. So let's start. Beta-lactams. So under this category falls penicillins, cephalosporins, and your atypical beta-lactams. So penicillins. One way for us to remember what the penicillins are would be anything that ends with cillin. Okay? So you have your examples of penicillins would be your penicillin G and V. So these are the very basic ones. So pen G and pen V they have a narrow spectrum. So meaning they only affect a small type of bacteria. Now, amoxicillin, it has an extended spectrum, meaning its scope or range of action is greater than your pen G or your pen V. So amoxicillin, this is a drug that we commonly prescribe to patients. And then another type of antimicrobial that falls under your penicillins would be your oxacillins. Now, oxacillins are resistant to penicillinase. Okay, what is penicillinase? It's anything that ends with ase. It's an enzyme, right? So it's an enzyme that would actually degrade your penicillins. So oxacillins, these are good. These are resistant to your penicillinase. So in case a bacteria develops this enzyme, then your regular penicillins will not work because it would just degrade your penicillins. So oxacillins, these are specially used for treating Staph aureus infections. Okay. Now, examples of um, bacteria that the penicillins would be good for or be good against. So we have your strep, your streptococci, your Neisseria, your Bacteroides, usually gram-negative rods and cocci. Then penicillins can also affect your treponema and some actinomyces species. Okay, one thing to take note of with penicillins is that they can cause allergic reaction. Okay, so that's why when you ask patients, when you're prescribing drugs to patient, you could always ask them, do you have a penicillin allergy? Because usually, if people are allergic to antibiotics, it would usually be the penicillins. Okay, now let's go to cephalosporins. Cephalosporins, one way to remember them is that they would start with Ceph, like a CEPH, or a CEF. They're pronounced the same. They're both Ceph. So cephalosporins. Now, cephalosporins would differ from your penicillins. For one, they are broad spectrum drugs. Now, people who are allergic to penicillins can also be allergic to cephalosporins. Why? Because it has 10% cross-allergenicity with penicillins. Now, cephalosporins has 4 generations, meaning there are 4 generations of drugs that's out in the market today, and we'll see it on the next slide. Now, some examples of cephalosporin drugs. So you have your cefazolin, so you see CEF. You have your cephalexin. Now, cefazolin and cephalexin are effective against E. coli and your methicillin-sensitive Staph aureus and your streptococci. Okay. Now, cefaclor would be effective against your Haemophilus influenza. And there's another drug, your cefadroxil, along with cephalexin and cefazolin. Now, these 3 drugs falling under cephalosporin, they can be used against your antibiotic prophylaxis. So what's antibiotic prophylaxis? We'll find out later. And then the last of the beta-lactams would be your atypical beta-lactams. So atypical beta-lactams would end in penem. Penem. Examples of which you have your imipenem, ertapenem, and meropenem. Now, your atypical beta-lactams, they're usually used with cilastatin. Why do we need cilastatin? So cilastatin is added to your atypical beta-lactams so that they would survive metabolism. Okay, so the effect of the drug would last longer. Okay, why? Because without cilastatin, what happens is the imipenem would be easily metabolized in the kidneys. So once it is metabolized, then the drug won't work anymore. Okay. Now your atypical beta-lactams would work usually with Pseudomonas aeruginosa and your gram-negative rods. Now on this next slide, these are just examples of what falls under penicillins, under your cephalosporins, and your atypical beta-lactams. So under penicillin, you'd see it here. You have pen G, V. You would also hear about penicillin VK. And then another group would be your methicillin, oxacillin, cloxacillin, dicloxacillin. So here you would see everything ends in cillins. Now, as I said earlier, the one that we usually prescribe to patients would be your amoxicillin. Okay? Now, under cephalosporin, we said earlier that there are 4 generations of the drug. And these are the 4 generations. So under the first generation, these are the representative drugs, and then second, third, fourth. What's common? They start with Ceph or Ceph. And then under atypical beta-lactams, you have your penems, your imipenem, ertapenem, and meropenem. Now, there are instances that bacteria, they get smart. Why would I say that? There are some bacteria that would form beta-lactamase. Again, anything that ends with ase, it's an enzyme. Okay, so what are beta-lactamases? Beta-lactamases are actually enzymes released by bacteria that would destroy the penicillin. So this is when they get smart. So if a bacteria that is previously susceptible to penicillin would be able to produce beta-lactamase, then once the patient takes in penicillin, what would happen? Nothing. The drug that worked previously will not work anymore. Why? Because it is able to make an enzyme, which is called your beta-lactamase. So this is what happens, when bacteria get smart. However, good thing we as human beings, we can also get smarter than them. So, what's the solution? The solution is to coat penicillins with substances such as your clavulanic acid, your sulbactam, tazobactam. They are added to the usual amoxicillin, ticarcillin, ampicillin, and your piperacillin. And so we end up with something like your co-amoxiclav or augmentin. So these are brand names. Co-amoxiclav. What does that mean? So co, it means they're together. What's together? Your amoxicillin and your clavulanic acid. Popular brand name of clavulanic acid and amoxicillin would be your augmentin. Okay, so here we can see that we can produce a drug, but then the bacteria over time can also produce enzymes that would be against that drug, making them resistant. And so we as men, we have to come up with something else to battle those or to combat those enzymes. And so this is an example of it. Okay, amoxicillin plus clavulanic acid, then we have your augmentin. Now, other cell wall inhibitors. We have two. We have your vancomycin and we have your bacitracin. Now, what's special about vancomycin is that it is narrow spectrum, but the thing that we have to take note of is that vancomycin is very effective against MRSA. What are MRSA? These are methicillin-resistant Staphylococcus aureus. Okay, so we said earlier that microorganisms or bacteria can produce something that would make them resistant, right? That's why in this case, some Staphylococcus aureus have become more virulent. In what manner? Now, even if you give that person a methicillin, nothing happens. The drug doesn't work on those patients. So what happened to them? Well, it just so happens that the bacteria has increased virulence, making them, resistant to the drug. So, again, what did we do? We found another way to combat methicillin-resistant Staphylococcus aureus, and that is with the use of vancomycin. Okay? Now, vancomycin is also used to treat intestine infections. Mode of administration is either oral or via IV. Okay? And another cell wall inhibitor would be your bacitracin. It is very similar to your penicillins. However, it's just topical. We usually use this for wounds, scrapes, minor scrapes. So it prevents minor skin injuries from becoming infected. So that's your bacitracin. So these are the different cell wall inhibitors that we have. Again, their target is the bacterial cell wall. They are effective against bacteria with cell walls. Now, another type of antibacterial drug would be your ribosomal protein synthesis inhibitor. So based on the name itself, they do target your ribosomal protein. And what are the two different ribosomal proteins? You have your 50S subunit and you have your 30S subunit. Antibacterial drugs targeting the 50S would be your macrolides, your clindamycin, and your chloramphenicol. Antibacterial drugs that would target the 30S subunit would be your tetracyclines and your aminoglycosides. All right, let's go first to those antibacterial drugs targeting the 50S ribosome. So we have your macrolides. Okay, so clue, macro, they end in thromycin. So when you see a drug and they end in thromycin, it is usually a macrolide. Now, macrolides, they are represented by your azithromycin, your clarithromycin, your erythromycin, your diarythromycin. Thromycin, right there. Okay? So that's for, easy remembrance. So mainly they're used to treat your ear, nose, throat infection, respiratory disorders, respiratory tract infections, skin infections, soft tissue infections, and some sexually transmitted disease. Okay? They are effective against your streptococci, your H. pylori, and your Mycobacterium avium. Now, macrolides can be used as alternative to penicillins, especially those with pen allergies. And this type of drug can also be used for antibiotic prophylaxis, particularly your azithromycin. Okay. Now, among these examples of your macrolides, erythromycin is safe for pregnant women, and it's safe for pregnant women. Okay, so macrolides, they end in thromycin. Now, lincosamides and your clindamycin. Okay, this is different. Earlier, they end in thromycin. Clindamycin is just mycin. Okay, lincosamides and clindamycin. Clindamycin is just has a narrow spectrum. It is effective against different streptococci, such as your Streptococcus pneumonia, viridans, and pyogenes. It is effective against your Staphylococcus aureus, but the basic ones, okay? They are not effective against the methicillin-resistant Staph aureus. They will not work, okay? So only the regular Staphylococcus aureus. Now, narrow spectrum, they are effective against infections caused by anaerobic rods and cocci. Okay, and then usually we can prescribe clindamycin for those people experiencing osteomyelitis. And we can also use clindamycin as an antibiotic prophylaxis, an antibiotic prophylactic agent. Okay. Some common brands for clindamycin, we have your Cleocin and your Dalacin C. Okay. Now, one thing to take note of regarding Clinda is that they're most often associated with pseudomembranous colitis. What does that mean? So, if a person would take too much of clindamycin, they can develop pseudomembranous colitis. It is a stomach disorder, okay? And so that's why we tell people, whatever was given to them, was prescribed to them, just take it. But anything beyond that, do not prolong. Because repeated use and prolonged use of clindamycin can give a person pseudomembranous colitis. Okay, that's Clinda. Now, another antibacterial agent against the 50S ribosomal unit would be your chloramphenicol. Now, chloramphenicol is a broad-spectrum antibiotic, not really used in dentistry because it is mainly used to treat eye and ear infections. Okay? Now, we go to antibacterial agents affecting your 30S ribosome. A very good example of which is your tetracyclines. Now, for the tetracyclines, example would be everything that ends with cycline. You have your tetracyclines, your doxycycline, and your minocycline. Now, Tetracyclines are broad-spectrum antibiotics. So they can they affect a wider range, you know, of microorganisms, such as, bacteria associated with periodontitis, refractory and localized aggressive perio. Okay, bacteria associated with acne. Then they also have an effect on rickettsia, chlamydia, mycoplasma pneumonia, H. pylori, E. coli, Borrelia burgdorferi. So see, broad spectrum. They target a lot of different types of microorganisms. Now, why is tetracycline famous in dentistry? We all know tetracycline can cause permanent staining of teeth if used during the second and third trimester or in children less than 8 years old. Okay. What is the mechanism of action that causes the staining? Well, tetracyclines, they bind to your calcium ions during mineralization. So once they bind to your calcium ions, then they would cause staining. They would produce brown, dark brown staining on the teeth of children. So when do they cause staining? If the pregnant mom takes it during the second or the third trimester, or if the child is born, the child is taking the medicine from 0 to 8 years old. Okay, so the number of teeth affected would depend on how early the tetracycline was taken in. If it's taken in by the mom, then more teeth are affected. If it's taken in by the child, then lesser number of teeth would be affected. Now, another thing to take note of regarding tetracycline is that the absorption of tetracyclines is reduced if the patient is taking oral antacids. Okay, oral antacids, so they are against your gastric secretions, so hyperacidity, GERD. So if they are taking oral antacids, then the absorption of tetracyclines might be reduced. Now, another thing that is common with tetracyclines is that Fanconi syndrome. Fanconi syndrome can happen with outdated drug use. If the drug is outdated and the drug is still used, then the person can develop Fanconi syndrome. What happens was the relationship with Fanconi syndrome and tetracycline? Well, the kidneys are going to be affected. Okay, so that's why you have to check. Check if the drug is outdated before even taking it. Now, tetracycline is also important. Has more importance in dentistry, as we said earlier, because it is effective against bacteria causing aggressive perio. And so, tetracyclines have a lot of use, especially when it comes to treating periodontal disease. Now, the special mechanism of action of tetracyclines that is against periodontal disease would be this. Tetracyclines would actually inhibit your matrix metalloproteinases, which breaks down your periodontal connective tissue. Okay, so basically they inhibit your MMPs and thus prevent breakdown of your connective tissue. Tetracyclines are very effective against your AA. Okay, and we know that AA, they are causative agents, primary causative agents of your periodontal disease. So what are examples of tetracyclines being used to treat perio? So here you have your periodontal plus AB. So these are actually tetracycline periodontal fibers. If you would take a look at these are like fibers. What do? You insert them in the pocket area. Why? Tetracyclines would inhibit your metalloproteinases from breaking down your connective tissue. So that's an example of tetracycline periodontal fibers. Now, another form that is widely used to treat periodontal diseases would be your minocycline microspheres. Brand name is Arestin. Okay. So these are microspheres. So as you can see, these are microspheres right here. It's injected into the pocket area. So Arestin, it's meant to stay there for the next 45 days undisturbed. And what is it supposed to do? It's supposed to treat the inflammation and improve pocket depths. Okay, so these are tetracyclines used in dentistry, especially in treating perio disease. Now, another type of antibacterial agent that is disrupting the 30S ribosomal unit of your bacteria would be your aminoglycosides. Aminoglycosides, examples of which would be your streptomycin, your neomycin, your gentamicin, and your amikacin. So route could either be IM, topical, or intravenous. Now, aminoglycosides, they're limited to aerobes. Okay, aerobes. Aerobes, oxygen loving. Anaerobes, they cannot survive in the presence of oxygen. So your aminoglycosides are limited to aerobes. They need oxygen. These bacteria need oxygen to survive. So examples of which would be examples of microorganism that's affected by your aminoglycosides would be your E. coli, your Enterobacteriaceae, your Klebsiella pneumonia, your Pseudomonas aeruginosa. Now, the route for your aminoglycoside, it's usually IV or IM. It's usually not oral because they are easily degraded. Okay. Now, streptomycin is a special aminoglycoside because it can also treat your TB, your tuberculosis. Okay. Now, common side effect of prolonged use of aminoglycosides would be your kidney and hearing impairment. Okay, so nephrotoxicity and ototoxicity. So that's a common side effect of using your aminoglycosides. Okay, now we go to your other antibacterial drugs. We have your nitroimidazoles. This is represented by your metronidazole or brand name Flagyl. Now, what makes metronidazole special is that it is limited to anaerobes. Again, anaerobes, they will not survive in the presence of oxygen. Okay, so these metronidazole would affect anaerobes, examples of which are your Bacteroides, your Fusobacterium, your Clostridium difficile, and it would also affect protozoans. Okay, metronidazole, anaerobes, and protozoans. Examples of your protozoans would be your Entamoeba histolytica, your Giardia lamblia, your T. vaginalis. Now, in dentistry, metronidazole can be used to treat acute ulcerative gingivitis, pericoronitis, certain periapical infections, and some cases of osteomyelitis and infected socket. What's common in all these things? Anaerobes. The infection is usually deep-seated, meaning it's not superficial. Okay? It's deep-seated, where you cannot find oxygen. Right? That's why periapical infections. It's down there at the apical area where you cannot see oxygen. Okay. Now, contraindications with the use of metronidazole. It's contraindicated for pregnant women. You cannot take alcohol and then take metronidazole. Okay, and also disulfiram use. What's up with disulfiram use? These are manifestations: cramps, nausea, and vomiting. Okay, now metronidazole can be combined with your amoxicillin to treat aggressive perio. Okay, they can work side by side, like simultaneously. So it can be combined, your amoxicillin, to treat aggressive perio. Remember, they have different spectrum. Metronidazole treats the anaerobes or affects the anaerobes, while your amoxicillin would usually take care of the aerobic and the facultative microorganisms. That's why they can be used. They can be used together because they treat different types of microorganism. Okay. Another type of drug would be your sulfonamides or your sulfa drugs. They start with sulfa, and your trimethoprim. So examples of which are your sulfamethoxazole, your sulfacetamide, sulfadiazine, your sulfacetamide. Now, these are effective against your Klebsiella pneumonia, your E. coli, Salmonella, Shigella, and your Haemophilus influenza. Basically, sulfonamides and your trimethoprim, they work by inhibiting the incorporation of PABA into folic acid in bacterial cells. So, PABA is needed by your bacterium. Okay? It is very important in the metabolism of your bacterial cells. So, if the drug inhibits incorporation of PABA into folic acid, then the bacteria will not be able to utilize it, and so they are inhibited. Now, sulfonamides, they are used in treating bacterial and fungal infection and urinary tract infection. Okay. Now, fluoroquinolones. Fluoroquinolones, they end in floxacin. So, if you're familiar with ciprofloxacin, norfloxacin, levofloxacin, moxifloxacin, then those are all fluoroquinolones. Now, spectrum-wise, they affect mostly aerobes. Again, you have your E. coli, your H. influenza, your K. pneumonia, Neisseria gonorrhea, M. pneumonia, L. pneumophilia. It's used to treat UTIs, your urinary tract infections, your respiratory tract infections, when other antimicrobials have failed. Meaning, this is your last resort, your last option. If all else have failed, then you can try this. So they are used to treat very serious infections. Why? Because these are very strong medications. So this is, your last option. Okay. So those are your fluoroquinolones or your floxacins. Now, we also have your anti-TB drugs. So anti-TB drugs, it's ripe. Well, if you consider rifampin and rifabutin, if you use them one by one, then you can do it riper, right? So your rifampin, your isoniazid, your pyrazinamide, and your ethambutol. These are the basic anti-tuberculosis drugs, anti-TB drugs, okay? Now, we mentioned this one earlier, streptomycin. It belongs to a different class of antimicrobial. It's part of your aminoglycoside, but it is also used to treat tuberculosis, okay? Again, you have your rifampin, your isoniazid, pyrazinamide, ethambutol. Okay? Now, here, these are just the mechanisms as to how they fight M. tuberculosis. Okay? So they inhibit either mycolic acid synthesis or the synthesis of your arabinogalactan or your DNA-dependent RNA polymerase. Okay? Anti-tuberculosis, ripe. Rifampin, isoniazid, pyrazinamide, ethambutol. Now, I have here a table of dose and frequency of commonly used antibiotics. Commonly prescribed antibiotics. So you have here for penicillins, your amoxicillins, amoxicillin plus clavulanic acid, or this is your augmentin or your comoxiclav, and this is your cephalexin. So it's just a reference. Okay. Yeah. Azithromycin. I don't think I mentioned this earlier, but common brand names would be Zitromax. Zitromax. And it's also commonly known as your Z-Pack. Okay. Now, what makes azithromycin different from amoxicillin, your cephalexin, or your coamoxiclav? Take a look at this. Z-Pack, you only take 500 milligrams on day 1 and then 250 milligrams on days 2 to 5. What does that mean? You only take it once a day. It's not like your amoxicillin, which you have to take every 8 to 12 hours or, every 6 hours. Azithromycin, this is easy. You take it 5 days, one time, once a day for 5 days. Okay, so that's why sometimes this is like a good option for those people who are forgetful, or for those people who would rather have the, like convenience in taking their medication. Z-Pack. Okay. Now, here, this is just talking about your antibiotic prophylaxis. I just got this. It's a literature review. So, listed here on table 1 would be cardiac conditions that would require antibiotic prophylaxis. So, what does that mean? Antibiotic prophylaxis, it means that we give certain patients antibiotic treatment, antibiotic prophylactic treatment. Why? It could be because they have undergone joint replacement, or they have certain cardiac conditions. So this is just to prevent bacterial endocarditis. This is why we give antibiotic prophylaxis. So this is just a list. It used to be a longer list, but now it's just this. These are the cardiac conditions requiring antibiotic prophylaxis. So, prosthetic cardiac valve, previous infective endocarditis, congenital heart disease, but not all. So, these are the conditions. It's unrepaired cyanotic CHD, completely repaired congenital heart defect with prosthetic material or device. So usually first 6 months after the procedure. And then there's a repaired congenital heart disease with residual defects at the site or adjacent. So that one. And then cardiac transplantation. Okay. Now, what is the standard antibiotic regimen for antibiotic prophylaxis? So usually, amoxicillin is prescribed. But for those who are allergic to amoxicillin, their other options are clindamycin and or azithromycin, your Z-Pack, or clarithromycin. Okay. Now, for patients who cannot use oral medications, then they can be given ampicillin, either IM or IV, or cefazolin, again, either IM or IV. For those patients who are allergic to penicillins but cannot take oral medications, then IV of clindamycin 1 hour before procedure. So when do we give antibiotic prophylaxis? 1 hour before the procedure. Usually. For IM or IV, within 30 minutes. Okay? Now, antibiotic prophylaxis guidelines. When do we give patients antibiotics? At-risk patients, not all patients, just at-risk patients. We give them antibiotic prophylaxis if the dental procedures that we will be doing on them would involve manipulation of gingival tissue or the periapical region of the teeth or perforation of the oral mucosa. Anything basically that would involve bleeding. Okay? And penetration of the tissue. Then we give antibiotic prophylaxis to at-risk patients. Okay? Now, we said earlier that antibiotic prophylaxis should be administered in a single dose before the procedure. And we said 1 hour before the procedure. However, in the event that they forgot, or the patient came into your office and you didn't know, you can still prescribe the antibiotics to them, and they can take it up to 2 hours after the said procedure. Just make sure the patient does not forget. Okay? Again, antibiotic prophylaxis should be 1 hour before. If they forgot about it, then they can take the antibiotics, the 1000 milligram amoxicillin, up to 2 hours after the procedure. Okay? Now we move on to antifungal agents. This is going to be short and sweet. Now, basically what we're concerned about with antifungal drugs would be something that would treat oral candidiasis. Okay? So oral candidiasis, or your thrush, it looks like this. There's white lesions on the surface of the tongue. There's white lesions on the palatal area. Now, when these white stuff are scraped off, then there would be red, reddish area, like bleeding. So that's how you know that it is caused by your Candida albicans. Now, what's the usual treatment for oral candidiasis? So you have your clotrimazole oral lozenges or your topical ointment. You have nystatin oral pastilles or rinse. You have fluconazole or ketoconazole, which is basically, for systemic fungal infection. And then you also have your itraconazole and your caspofungin. This is administered via IV. Now, a famous antifungal drug is your amphotericin B. Amphotericin B, it is used for most systemic fungal infections. Okay, so dentally speaking, we don't really use this as much. Okay, we stick to nystatin and clotrimazole. Okay, so that's your antifungal drugs. Your azoles, your ketoconazole, clotrimazole, miconazole, fluconazole. Okay, antifungal drugs. Short and sweet. Now we move on to antiviral. Antiviral drugs would usually end in vir. Okay, examples of which are your acyclovir, valacyclovir, famciclovir, vanciclovir, well, except for amantadine, and your zanamivir. Now, antiviral drugs would usually attack the mechanisms used by the virus to replicate and infect. So, examples of which would be these antiviral drugs would inhibit viral DNA polymerase. It would inhibit viral RNA-dependent DNA polymerase. They can also block the uncoating of your virus. Now, in dentistry, what we are most concerned with would be your herpes simplex virus, your varicella zoster virus, your cytomegalovirus. Okay? Influenza A and B, well, not really dental related. So here you can see in this picture, herpetic lesions. Okay, so these are examples of herpetic lesions. What is the drug that we can prescribe to patients in case of herpetic lesions? Acyclovir. Okay, that's basically it. So these herpetic lesions, they're caused by your herpes simplex virus. Okay, varicella zoster virus, we know this as what? Causative agent for your chickenpox. And herpes zoster. What's herpes zoster? This is when your chickenpox recurs because the person is under stress, or the immune system is compromised. Then herpes zoster can sit in. So usual clinical manifestation would be either vesicles or ulcers, which would, like, if you find it on the skin or on the lips, they would usually crust like this. But if you find it in the mucosa, they're usually concentrated in the hard palate. Okay, hard palate and hard gingival area. Okay, and again, treatment would usually be just acyclovir. Okay, and that ends the typical antimicrobials that we use in dentistry. Okay, hope this helps.